शायद लोगों को पता चल गया कि बाद में ये लेक्चर YouTube पे मिल जाएगा, इसीलिए नहीं आ रहा।
Good morning. Today we are going to discuss some important topic, that is somatic and psychological symptoms of depression from general physician point of view. So we will discuss the diagnosis of depression in medically ill and the somatic or pain symptoms when the patient present to any OPD. The patient does not know that he is suffering from depression. He has some symptoms and some signs also. He comes to the doctor to tell his symptoms and signs. He or she does not know the diagnosis. So it is up to the doctor to interpret his signs and symptoms and put it in a packet called disease. It is a syndromal approach. So what happens when, in addition to physical illness, psychiatric problems they creep in, like depression and other somatic symptoms, then the patient is at confusion and doctor also, because the doctor cannot explain the symptoms what the patient presents with his the bracket of a syndrome called disease, like diabetes. The doctor believes that the patient will tell 1, 2, 3, 4, 5 symptoms, and the doctor will interpret he is suffering from diabetes or hypertension. He will find some signs or arthritis or fracture of a bone. The patient must tell some signs and symptoms, and doctor will interpret. Sometimes what happens, other symptoms they creep in, which make the person to tell the most important symptoms that he feels it's important to him or her. Like what happens in disease depression, the patient has a magnifying glass. The patient may interpret some minute symptoms in a very bigger way and forget to tell most important symptoms which doctor wants. Then the doctor gets confused. What happens? The patient's all symptoms point out to a particular disease, but he cannot fit all his symptoms into a diagnostic criteria. Then there occurs confusion. We will discuss about these things today. The depression is one of the most important diseases that is going to afflict the mankind. The WHO has predicted it will be one of the most important diseases by 2025. Almost 50% of the patient who will attend to doctor will have some other symptom of depression. So it is very important from the general practitioner's point of view to recognize depression, because it is very important. If the person is depressed, he is not likely to follow your advice. So there will be treatment obstacles. The doctor will prescribe some medicine, the patient will not take timely. Then a depressed patient has wished to die. If the doctor says this is a very important medicine you must take, the patient will smile at his or her heart. Oh, this doctor is telling this is an important medicine. If I stop it, probably I will die. So the patient will feign you as if he or she is taking the medicine regularly and silently throw away that particular medicine which you will tell is very important. So that is very difficult for a doctor. I have seen many patients in OPD, doctor is increasing the glycomet dose, 500 milligram, 1000, 1500, 2000, 2500. Doctor is confused, so sugar is not coming down, and the patient are telling, sir, I am taking regularly. Because the patient believes in her heart, if I stop this medicine, probably I will die, which is my goal of a depressed patient. So a diabetic with depression will not stick to the treatment regimen that the doctor prescribes if he or she has suicidal ideation. Also, the depression itself makes the person very lethargic, poor compliant to the medication. These are few important issues, very important for a doctor to know. So, and most of the important medical diseases or disorders have depression, like a CVA. It has been statistically found out that 50 to 60% of CVA patients have concurrent depression. Like Parkinson's disease, about 60% of people with Parkinson's disease have concurrent depression. Diabetes, 40 to 50% of diabetes population will have depression in their regimen. and this the medical disorder may mask comorbid depression. So the patient is very ill, he is crying, telling the doctor, I am suffering from a very serious illness which you have to treat, otherwise I am going to die. So whether it is a concurrent syndromal diagnosis of depression or diabetes with chronic suffering, that the doctor is unable to decide at that point of time. But it is very vital from the doctor's point of view. If they recognize depression and start treating with antidepressants which are very safe nowadays, it can be prescribed with a heart patient or to a diabetic patient, to most of the physical diseases. They are very safe antidepressants where the doctor will get immediate relief. What the doctor wants, the patient must say, I am getting relief, you are a good doctor, your treatment is very good, you are an excellent doctor, I will do follow up with you. A private practitioner always wants that. The patient should follow his or her regimen, the patient should get cured, and the patient must recognize that doctor's intervention has helped him or her and make few other patients to follow his or his doctor. That is any private practitioner's goal. So that goal will be totally blocked if the person is depressed. The patient will get cured of his diabetes, but he will not satisfied with the doctor because he is depressed. He will tell 5 others, this doctor is not good. His intervention is not making me improve of the disease. What is the disease? Depression. Because the doctor is unable to recognize at the right time and not given intervention. And most important thing, nobody wants to go to a psychiatrist. Always everybody wants to go to a physician. So it is also physician's point of view, recognize psychiatric disorders and treat them before sending you to a psychiatrist. For a depression, if you send to a psychiatrist, say, am I mad? Why are you sending me? So you will be doing 2 wrongs. First, he will stop going to that physician. Number 2, he will ask other patients not to go to that particular physician, and him or herself will not take treatment. So for depression, anxiety, now WHO says that all general medical practitioners, all physicians should be conversant with depression. They must start treating depression. If the person is a resistant depression and is not respond to your antidepressant, then only you send to psychiatrist. So if a person is coming with vague physical symptoms, one must be very aware whether the person is suffering from depression. That diagnosis must be kept in somewhere in your mind. The symptoms that the patient is telling is not fitting to that particular disease. After your rightful intervention, the patient is not improving, or even if it is improving, patient is not recognizing that she or he is improving. Then always somewhere in your mind you should keep a clip of depression, fit the symptoms into the clinical picture and find out if the person is depressed or not. Actually, patients come with some signs and symptoms, and all psychiatric disorders are full of mainly symptoms and few signs. You have to particular fix a psychiatric disease. You will not find a blood test will be normal. In a depressed patient, blood test will be normal. X-ray, ECG, all things will be normal. So your all this clinical diagnostic acumen only identify the physical disease. Psychiatric diseases, you must be aware that they present with only symptoms. Hardly you will get any telltale signs where you can say that yes, this person is depressed. Now currently 1 in 5 primary can visit for new symptoms, for no specific cause can be found. This is it is in published in Journal of Psychosomatic Research. This is the finding which the general physicians themselves has told. In any medical outpatients, you will find that this about 23%. They present with the diagnosis of depression, but they are not diagnosed. Why? Because we don't develop during MBBS career. I have our psychiatrists have done a lot of study. They found out this all medical graduates, they hate the subject called psychiatry. They will not read. Only there will be 5 short 5 marks in short note, they will never read psychiatric topic because they are afraid, and that is true. That is true. It is very difficult to go to psychiatric chapter and understand the disease. Very difficult. So most of the MBBS doctors, they don't go to even touch that topic psychiatry. Therefore, it is obvious that they themselves are unaware about the psychiatric symptoms, psychiatric disease. Therefore, it is not wrong in their part not to diagnose them. So, out of the 47% with the mood disorder, that is major depression, only 8 was recognized. So 2% was recognized. It is at the America, not in India. Even in America, general practitioners, they are not able to recognize depression in OPD with so many education parameters. It was published in Acta Psychiatrica Scandinavica. So this internal medical physicians, now we are not considering about general practitioners. Even the doctors during their MD medicine, they are afraid to read this psychiatry. Now rightfully the curriculum makers, they have decided that psychiatry will be individual paper where the person have to pass. Otherwise, he will not be given MD medicine. They are thinking in that aspect. So, if you don't pass psychiatry, you will not be given MD medicine. That now they are considering, because psychiatric results are becoming very, very important. By 2050, 50% of the population coming to hospital will be suffering from some or other psychiatric problem. It has been predicted. So it will be your bread and butter, and it is for any physician in their interest to study psychiatry and recognize the basic psychiatric diseases and treat them at their OPD level. And unrecognized depression has a higher morbidity and mortality rates in medical ill patients. So it in a way affecting their outcome. In government setup we can relax, but in private setup this is very, very important because it is their bread and butter. So it is published in Canadian Journal of Psychiatry and Circulation. They found out that the cardiac patients, any myocardial infarction, 50% of the population will have psychiatric problem during their long-term follow-up, and their mortality and morbidity increases 6 to 8 fold if they are not diagnosed and treated at right time. Also in diabetes, hypertension, Parkinson's disease, cerebrovascular accidents, they have a high degree of depression during their long clinical path to recovery, and it is in our interest to diagnose and treat. So there are a lot of scales, but it is what happens in a BG OPD setup. It is very, very difficult to put a psychiatric scale and to assess. Very, very difficult. So the physician must develop 2 or 3 important questions, vital questions, and put it to the patients. Put it to the patient. Because nobody in the OPD setup ever follow a questionnaire, and more so in government setup. Government setup, it is very, very difficult. Even psychiatrists are unable to put a full-fledged questionnaire and find out actually the percentage actually result. It is very, very difficult. So to identify depression, 2 most important questions you must put. How are you feeling during your day-to-day activity, whether you are enjoying your life? That particular question will tell telltale sign of depression. Because sustained sadness of mood, the person will not become happy whatever you give to him. Sustained sadness of mood and reduced interest in all pleasurable activities. You just ask how you are enjoying your television. TV serials. Tell me about some of the important TV serials. This is very important question. And depression is more prevalent in women than men. So if it is a female case, you just have chart. So initial 2-3 minutes, instead of asking how many times you urinate in a diabetic patient, you ask how are you enjoying your life. Tell me about some important serials. But if the person is telling more and more, stop, we're not depressed. If the person is, in spite of asking, not responding, he telling that no, oh, these TV serials don't entertain me, aware, the person must be depressed. Very important. You must develop your own set of questionnaire. You don't put it to the last. All psychiatric questionnaire, 1 or 2 lead questions you put at the beginning. Because if the person is not depressed, it will build up a rapport. If not depressed, if depressed, you will clinch the diagnosis of depression. So the immediately you put such important question, the person will believe doctor is very interested in me. So he is a good doctor. He will treat me properly. But be careful. After putting such question, you must know where to stop. If the person starts telling about different serials and goes on, your OPD will be disturbed. So if he starts telling very cheerfully, stop her, stop him. Then now you have ruled out depression. Mostly. So these are the 2 important scales: hospital anxiety and depression scale, and this conscious depression they do in America. But in our setup, where you see more than 100 cases per day, it is very difficult to put any standardized questionnaire. There they see 10 to 12 cases per a day, and they do lot of assessments. Still, at their level, they fail to recognize depression. That is the beauty of this presentation. Always doctor very much concerned in the busy practice. He tells the patient should give me a sign which I will put immediate diagnosis, correct diagnosis. So even though the signs of somatisation depression there, we may not see them. Wow, how? From Hippocrates to Galen, they have found out so many signs and symptoms. So history is full of signs and symptoms which the doctor will not able to recognize. So the person may have symptoms of spinal irritation, consult to a neurologist. No neurological problem, but the patient may show signs of irritation. They may interest to the orthopedician. They come with back pain and associated peripheral symptoms, which would purely signs and symptoms of depression. After doing MRI and all investigations, you will find that nothing is coming out. But learn, the patient is suffering. You are unable to give a diagnosis. It is not concerned to the patient. The patient is suffering and the person believes the doctor is not able to understand my disease. So the medical science is useless. They are not able to understand I am suffering. And the doctor is unable to recognize. That is called depression. So they may have paralytic symptoms. They have catalepsy, multiple personality. So they may almost mimic any neurological disease. And learn, the patients are not malingerers. This diagnosis is made after removing all malingerers from the clinical forum. These are not malingerers. They are actually suffering. And doctor is not able to recognize because they are telltale signs and symptoms of depression. So this is, sorry. It is published in New England Journal of Medicine. They found out that 69% of the patients who have visited primary physicians, they reported only physical complaints, but they were depressed. No other diagnosis, no physical diagnosis. Depressed patients 69% they come with the doctor because they have hidden the psychological symptoms, because otherwise people will consider them mad. So they hide the telltale signs of depression. They come up with physical, sir, I have a terrible headache, I have difficulty in sleep, physical symptoms. So, and they present with the unexplained somatic symptoms. The doctor is puzzled. I am not able to fit to any diagnosis. What has happened to this patient? So, this is the clinical picture they presented with. It is published in American Psychiatric Association Journal and also this Archivist of Family Medicine. Any possible symptoms, they may come with all these emotional signs of depression, or they may hide all it is, because they will say that this, they also now read internet. Their patients, before coming to doctor, you will be surprised to know in any city setup, they go to internet, study their symptoms, take a voluminous printout, go to informed relatives, go to important people in the neighborhood, discuss about their diseases, then they come prepared with a band of armaments called signs and symptoms to fight with the doctor. That is the duty of depressed patient. They come to fight with the doctor. They want to assess the knowledge of the doctor. They want to test the doctor. So they will conveniently hide all the telltale signs of depression and will come with only important physical symptoms. And they will enjoy when the doctor is unable to diagnose.
An example of anhedonia?
Sir, anhedonia is a loss of interest in all activity. They will be very lethargic, they take no interest in any of the day-to-day activities, anhedonia. Sir. So, but it is anhedonia, you have to observe and ask the relatives. What happens mostly, we diagnose psychiatric disorders by asking the relatives more questions than the person, because depressed patients, they are very less productive. You ask them 10 questions, they will answer 1, and you will get bored in a very busy setup. You asking questions and patient is only his mom is not responding. You become irritated. But I have so many cases in life. How many times I will ask you this question? You are not answering. So at that point of time, keep a important switch in your mind. If your reaction is like this, probably the patient is depressed. You ask your house staff. If I react in some way to a patient, you write the diagnosis depression. That is the beauty of medicine. You become irritated, your house staff diagnoses that patient is depressed. That is the beauty. So that is the importance of keeping house staff and DMP students. So they may come up with so many physical signs of depression. And you have to be aware, because it is your bread and butter. If you go to after age of 60, after retirement, go to private practice, this knowledge will come. During government service, you don't bother. The less number, sorry, it is being recorded. So, the physicians diagnose depression in response to psychosocial presentation. If the person comes with some psychosocial problem, physicians are able to diagnose depression in a better way. But if the patient is coming with physical problems, it is very difficult, because obviously due to his long, hard effort, he has learned few signs and symptoms to diagnose a physical disease, not psychiatric problem. So it is not unjust in a physician's part not to diagnose depression. So if the person comes with psychosocial complaint, 77% of the patients will be recognized as depression by a physician. But if he comes with a physical problem only 22%, that is about 78% of cases you will miss diagnosing depression. This is published in American Journal of Psychiatry. But what is important? The more number of physical symptoms the person has, and you are not able to fit in a medical diagnosis, the chances of diagnosis of depression increases. They found out that if the person has more than 9 physical symptoms which you are unable to put any medical diagnosis, the person is surely depressed. He may not say, I am hopeless, worthless, I have crying spells, I want to do suicide. This all he can hide. But if you are getting more than 9 signs and symptoms which are not, you are able to put in a particular bracket of called disease, you must say your house staff, diagnose depression before I can diagnose. It is published in Archives of Family Medicine. Then physical symptoms, these are the positive predictive value, and this is if the person is having greater than 3 complaints and having fatigue in one of their, where I am feeling very fatigued, doctor, I cannot do my duty, and you find he suffering from no disease. I cannot go to work. I have not worked since last 6 months. I am putting myself in sick list. I am not able to go to work. And these people are telling, I have no problem. I visited 5 physicians. All of them they told you are useless. You don't have any disease. Why don't come and take my valuable time? Depression. This is published in Journal of Internal Medicine. And back pain, musculoskeletal pain, orthopedician, they have high number of depression patients visiting their OPD. So, if the pain is very diffuse and at multiple sites, which you are not able to put any diagnosis, think depression. And you don't find a disease, but the patient says that it has interfered my general work, it has interfered my family life. Depression. So they found out that in depressed patients, they come more with pain and GI symptoms. This is published in Archives of General Psychiatry. So this is very important. If you have no mood disorder, the symptoms will be this severity. If they have depression, you see how much magnified the symptoms become, because they are looking the symptoms with a magnifying glass called depression. What happens? The depression lowers the pain threshold. If you are able to bear X amount of pain, if you are able to 10x amount of pain when you are not depressed, the X amount of pain will elicit 10x response in a depressed patient. That is the beauty of depression. Pain may also precipitate depression. So if there is like orthopedic diseases, there are so many, because now more and people are living beyond 80 years, beyond 70 years. They are developing lot of pain symptoms and syndromes and associated depression also. You have to treat both of them to be a good orthopedician, good general physician. So now to conclude, because I have to leave stage to Dr. Mahamaya Sharma, who will discuss a very important topic. So many people coming to a general physician with a set of signs and symptoms have hidden depression as a packet. They want to deliver and doctor don't want to accept. And unless you accept the patient, whatever patient is offering, you will not be a good physician. Or accept whatever the patient offers. Take whatever you want to take. Throw away rest. Take all the signs and symptoms with smiling face. Recognize depression. Recognize physical illness. Throw away which is useless. That is the beauty of a good general physician. what happens sometimes you will get in general OPD signs and symptoms of physical illness presenting a depression because a learned, highly intellectual patient wants to hide all symptoms because they don't want to be called mad. So they will go to internet, read several books, go to different people around their area, screen out all symptoms of depression and will present with a basket of symptoms called physical signs. So if you have more number of physical signs and symptoms which you are unable to put in a particular bracket called diagnosis, think depression. There are now a lot of medications, safe medications available. One of these beauty medicines is sertraline. Very good. It can be given to heart patient, it can be given to a kidney patient, kidney disorder patient, cerebrovascular accident patient, diabetes, all physical. And another is this tianeptine. Sertraline and tianeptine we recommend for all general physicians. They must go and read in detail about this. These two will be bread and butter. You don't remember so many psychiatric medicines. That is psychiatrist's job. He is paid for that. Don't read so many psychiatric drugs. Read only one or two in clinical detail so that if you corner a psychiatrist, you will excel. That is the beauty of a general physician. He reads less and less about psychiatry, masters more and more about depression and becomes a beautiful physician. Thank you. You go to what?